So what we've looked at in our analysis was overall survival is normally considered the most patient-relevant endpoint in clinical trials. So we want to see that our patients are actually living longer from what therapy we're giving them compared to the control arm of any other therapy. So we want to see that their lives are actually prolonged and that this prolongation of life is actually meaningful. And because of our advances in therapy, this endpoint of overall survival is getting pushed further and further into the future. And now we have trials which are exceeding, so they're reporting after more than 7 years, and we still haven't reached a median overall survival. So it's getting harder and harder to reach this endpoint and to actually read trials out quickly enough so we can get these new therapies to patients. So what people have been doing, and which is considered a normal endpoint in CLL trials, is using progression-free survival rather than overall survival to expedite study readout. So this is a composite endpoint where the patients reach the endpoint if they've either died or if they've experienced a progressive disease. So with this, you can see how long can we push the progressive disease ahead and then compare those therapy. But do these really correlate with each other? So if we prolong the progression, do we actually prolong the lives of patients? Can we use this as a marker to expedite study readout, or are we using something which doesn't really help the patients? And that is a matter of discussion. And so we've looked at 12 different trials from the German CLL Study Group to find out, do these actually correlate? And we've used different statistical methods basically on the trial level, so compare different trials and their hazard ratios for PFS and OS at different time points, as well as individual patient data for patients which have actually died during the follow-up of the study, to see if both of these events actually correlate with each other. And we found out that they actually do correlate quite nicely, so we can be confident in assuming that this is actually true, what we're doing, and this is actually for the patient's benefit. And of course the question arises, is this true even in the advent of modern therapies? So now we have a totally different therapy setting compared to 5 or 10 years ago, and now is this still true? And what we found is that it's actually a bit better, so the correlation is actually better, which gives a lot of room for interpretation, which I think we're gonna go into more if we publish this as a manuscript. But it's reassuring to see that this holds true for targeted therapies as well as chemoimmunotherapy. And then we took another look, because it's not only PFS which is used, but also minimal residual disease. So can we measure how many CLL cells are in the peripheral blood? And because this is more and more used as a surrogate endpoint in clinical trials, we wanted to see, does it correlate with overall survival and progression-free survival? And it does. And it does quite strongly from what we found, both for chemoimmunotherapy and for targeted agents. So to summarize, we found that these commonly used surrogate endpoints actually do correlate quite nicely, but of course we have to take a deeper dive and see and find out if this holds true in all of these settings which I've just mentioned.